All right, let's do this. If you are new to Clinical Athlete or the CALU communities, or this is your first journal club, we'd like to welcome you. As many of you know, Clinical Athlete and the Level Up Initiative are joining forces. And one of our first orders of business was creating a free community for networking and brain gains, as well as organizing regular events like this to continue to keep these going. So I'm going to drop the link to the free CALU community Facebook page in the chat. And I'd recommend clicking that link and requesting to join that group, because that's where we're going to be keeping you guys all up to date. We're going to have awesome things happening. These journal clubs, keeping these going on a regular basis, live case studies like we did last week, and monthly Zoom calls for students, and just a whole lot of awesomeness, great discussions within the group, different resources posted all the time. So join that group if you're not in there already. And as far as participating in tonight's meeting, you've got a few options. So we've got a decent group tonight. So we got almost 60 here now. You're free to join the conversation as you wish. You can just unmute yourself and start talking. But if it starts to be a little crazy with so many people, where like 7 people unmute themselves at the same time, what we'll have you do is just type the word question or comment in the chat, and then that'll prompt us to say, go ahead and so you can unmute yourself. The floor is yours. If you'd still want a question or a comment to be discussed, but you don't necessarily want to unmute yourself or turn your camera on, you just want us to read it, you can type question or comment and then type your question or comment in the chat. And that'll be a cue for us that you want us to use the question or comment in the discussion. Otherwise, you can use the chat as just kind of a sidebar to have your side discussions. People drop references and links in there all the time. The chat is really useful for some just awesome side discussions. So feel free to use it as you wish. And of course, you can just be a active listener and soak up all the brain gains if you'd like to do it that way as well. We will do breakout rooms right around halfway through. I always say that ends up being time gets away from me, but Megan and Kevin will keep me on task here. These meetings are open to anyone. We do record them. You'll get the recording in the next next couple days after the event, and you'll have access to that for 7 days prior. So if you want to rewatch it and pick up more nuggets, you can do that. I'm also going to put the links to the papers in the chat right now. So that first link is the Fernandez paper that we'll talk about mostly. And then the second link is the Patterson review. So those 2 links will take you right to the full PDFs. So if you didn't get a chance to download the papers, you can do it right there. It'll take you right to the PDFs, full paper. And just a quick note on sound. If you were unmuted and then you are not unmuted, but you're not talking, just try to remember to mute yourself so that no background noise comes in. Otherwise, we'd like to welcome you guys to Clinical Athlete Journal Club number 35, or more formally, the first CALU Community Journal Club. My name is Quinn Hennick. I'm a proud clinical athlete provider. I am joined by Kevin McNamara, a physical therapist in the Seattle area. He's been a part of the clinical athlete community for a long time, and originally the one responsible for bringing these journal clubs to life. So thanks for being here, Kevin.
Of course, Quinn. Exciting times. Before we get started, though, question: Bama or OSU tonight? Who you got?
It's on. I've got it on DVR, is what I've got. But Bama.
Bama. I like Bama. I'll take the over. Clemson left me a little light in the wallet after last week, but
man, let's hear it in the chat. Clemson or Bama? Who you guys going for? For anybody who's like sporting things, this is college football championship tonight. Go Buckeyes. We've got some Ohio State peeps. I'm a Midwest guy, but if you're not an Ohio State fan, you're usually an Ohio State hater. That's how that works. I'm an SEC guy in general. Okay, and we are joined by Megan Broussard, who is a student PT down in Texas at UT Southwestern. Megan, who are you going for tonight?
Neither.
Oh, okay. Wow.
I don't know. I agree with
Buzzkill. What did Jeremy say? Oh, neither. Who's going to win?
Neither,
Okay.
but Bama's gonna win.
There you go. Okay. Sounds official to me. In case you guys are curious about the motivation for these meetings, we drew the inspiration from Benjamin Franklin, because he started a meeting way back in the day. They called it a Junto Club. It was a mutual improvement club. And it was just a room full of really smart people. And they talked about all the important issues of the day. And we've adopted their motto, which is these meetings are conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. So we welcome discussion. We want, we all want to be less wrong. We're on the same team here. We're not looking to win, but I think we all come out of it with some positive to gain. So tonight's journal club topic is blood flow restriction training. Got a couple questions that I want to launch to the crew here. That poll just popped up in front of you, I think. So who are you? Are you clinician, student clinician, coach, student coach, trainer? And number two, have you used BFR, blood flow restriction training, in your practice or your training, either yourself or with your athletes in the past? A lot of students tonight. Awesome. Some coaches too, lots of clinicians. Looks like we're almost 50-50. The small majority, I'll share the results here. So a little over half have used BFR in some capacity in the past. And those who haven't, this will be a nice starting point for you. I would definitely check out the Patterson paper, because that's more of a review for the topic in general. It's a really good review, even up to this point. It's like I think it's a couple years old now or coming up to it, but I would definitely read through that paper if you're interested in BFR in general. Okay. So the two papers, the Fernandez paper came out in December of 2020, and it's titled "The Effects of Blood Flow Restriction Training on Hand Grip Strength and Muscular Volume of Young Women." And the Patterson paper was a review back in May of 2019, and that's titled "Blood Flow Restriction Exercise: Considerations of Methodology, Application, and Safety." That paper, the Patterson paper, is going to be more of a reference for us, as just kind of a reference for the topic in general, but it's really good. It gives you some protocols for implementation, and it gives you the current evidence on safety. So that should be one of those papers that you refer back to on this topic in general, if you're looking for information specific to BFR. But we're going to talk about the Fernandez study. So they had two groups. They were interested in figuring out if blood flow restriction of the upper extremity in conjunction with a grip training program, low intensity grip training program plus blood flow restriction, yielded greater strength adaptations in grip and also muscular volume or muscular hypertrophy in the arm, versus a group without BFR, but with heavier intensities. So two groups doing a grippy resistance training program 3 times a week, 12 sessions total. And one had BFR working at lower intensities. One group did not have BFR working at higher intensities. And they were looking to see any differences in strength adaptation or muscle volume. Kevin, what did you think about this paper?
Yeah, so I've been trying to figure out a good way to put this lightly, but this paper's trash, bro. I'm sorry. I was confused how you come to the conclusions that they did in kind of the abstract of the paper, when within the paper itself, you're looking at the raw data, and they even say within the paper itself that the values of arm circumference, right hand grip strength, left hand grip strength were very similar between groups. So it seems like pretty rapid departure to me, when in the abstract, the conclusion itself is that dynamometer training with blood flow restriction performed with low to moderate loads was more effective than traditional training in increasing hand grip strength and muscle volume in young women. So I'm not gonna lie, I was a little confused how they kind of reached those conclusions, given the data that they actually supplied. And it's just, I think it's a problem when like the strongest evidence that you report is from papers that are not your own, kind of in the conclusion. So I'll be honest with you, it was an interesting read for me. I didn't really follow.
So I threw it to you so there could be good cop, bad cop, and you could be the bad cop, but it's going to be bad cop, bad cop. So I'll give my thoughts too. And if you get the sense that, we're pushing back on this paper a little bit, that doesn't mean we're right. So we want to hear everybody else's thoughts as well. But so let's look at the exercise programs first. The group that got the BFR, both groups train 3 times a week for 4 weeks, or 12 total sessions. And I'm pulling up the paper so I don't mess this up. But in table 1, you can see the protocol. The BFR group trained in incremental increases in intensity starting at 30% and ending at 55% after week 4. So in that 4-week period, they were training at roughly 30 to 55% of max volitional contraction, which they tested before the exercise program. They tested on the dynamometer, then they just took a percentage of that to train the contractions. They didn't give a picture or anything about exactly what the exercise was, but they described it, and it's just you sitting in the chair, pumping your hand like this on a dynamometer is what I gathered from it, if I'm misinterpreting that. But there was no elbow movement. It's just hand, 4 fingers, boom, boom, just like that. And if you're new to BFR lit and you're thinking like 30 to 55% 1 rep max, that's so light. That's pretty standard for BFR. Even, I mean, I've seen studies as low as 15% 1 rep max with BFR and showing muscular adaptation. So that's kind of the point. And we're going to get into low load versus high load, effort match versus volume match, these types of things, because this is really important. And there's some issues in the discussion. But so take that from the BFR group, and then the traditional training group. Traditional training in BFR literature usually means higher load, no BFR with higher percentages of 1 rep max, usually 70% or 60% and above, kind of depending on the paper. But in this case, in week 1, it was 65%, to week 4, 80 to 85%. So that was the range. Now, where are they getting these percentages starting and finishing? It's all arbitrary, as is lots of the things in our profession. Where's the inflection point from low load to high load? Nobody knows. It's usually that 60 to 70% mark where we consider it high load. Anything below that is considered low load. But I'm looking at like the dosage, and it was both groups went to failure, which was good in a sense that we can anchor it in that standard. So 3 sets, every time you came in to the exercise program, you did 3 sets to muscular failure. The BFR group did 15 to 25 repetitions, and the non-BFR group did 8 to 12. Where they're picking these, repetition ranges, who knows? But if both groups are going to failure, the BFR group is essentially doing double the volume.
Yeah.
So they're getting double the exposure. Now,
yeah, I'm glad you brought that up, because that was one of the biggest things I had too. Is like, it's almost like the way that they set up the programming was inevitably going to favor BFR. Because if you think about it, you're moving like a 70 to an 80% max load, and I think it was 30 seconds between sets was kind of the protocol for that.
For BFR, and then it was a minute
Yeah.
So what they didn't equate volume from a volume load or a tonnage standpoint. They equated volume from a time standpoint. So they said each one of these sessions takes the same amount of time, and so volume is equated. But that depends on how you define volume. So is time what is creating the adaptation, or is it the exposure to the stressor of the exercise? And if we look at it from that perspective, the non-BFR group is doing a lot less from a total work standpoint. Also, 8 to 12 reps is a pretty narrow window. What if they hit failure at 20 reps or hit failure at 6 reps? It didn't talk about if anything was adjusted. And Taylor in the chat brings up a really good point in saying they, not understanding why they didn't find max occlusion pressure, the individual arterial occlusion pressure of each person, and then take a percentage off of that in order to standardize the occlusion pressure. They gave it 160 across the board. So, for these women, 160 could be really tight. That could be 90% occlusion, and it could be 40% occlusion. Now, you can get BFR adaptations in a wide range of occlusion pressures, but the sensation is going to be much different if you're at 80% occlusion versus 40% occlusion. That's going to dictate where you quote unquote reach muscular failure from just a perception level.
Yeah, I think that's a good point, because we do see that it's not necessarily being the exact LOP that's really important, but kind of being within that range. But also, if we're talking about like limb circumference, that's going to play a large role in total limb occlusion pressure. So it's not to say that it could be wrong necessarily, because they could have very well been within that range, but I think it leaves a little bit too much of an unknown, because like you mentioned, sensation is going to be different, and you may not even be getting the adaptations if you're outside of kind of like that bandwidth of limb occlusion pressure. So definitely something that they kind of missed there.
And again, and if anybody wants to join in, unmute yourself and just go, because I got a couple more minutes here. Now, we always say, science and research is hard. So kudos to the researchers for getting 28 people to be able to do their study over the course. Training studies are difficult. Getting people to come back over and over 3 times a week and only lose 2 people, 1 in each group, like, good on them. However, in table 3, let's talk about the actual results. So to Kevin's point, what do we actually find? Well, if you only read the abstract, you found that the BFR group gained volume in their arm, which we used as a proxy for muscular hypertrophy. And they increased strength in both hands in the BFR group versus the non-BFR group only increased strength in their left hand. But let's look at the actual data, which is on table, I'm bringing up the wrong thing here, table 3. So what do we actually find? Well, first of all, there were no differences between the groups. There were only differences pre to post in the same group. So that's kind of misleading in itself. You assume, the BFR group increased arm volume and grip strength significantly greater than the non-BFR group. That's not actually what they found. There were no significant differences when you compared each outcome between the groups. So that's an important distinction. And number 2, when we actually look at the changes here, arm circumference was measured, just measuring between elbow and clavicle, just taking a measurement right here, arm circumference. And then arm muscle circumference was an equation based off of that, as well as a tricep skin fold test. So what they found was a significant increase in arm volume and arm circumference. It was a 1 centimeter change for each of those things over 4 weeks, 1 centimeter, with a standard deviation that was double that. So we have standard deviations that are double the mean change. So what that says to me is I'd really like to see the raw data. And what I'm guessing is there was quite a bit of variation. However, that doesn't even matter, because somebody clear this up for me. What was the exercise? Sitting in a chair and doing this. How is upper arm volume relevant to that intervention? Kevin, anybody, am I missing something?
No, you're right. Like, why? Because I'm just chalking that up to measurement error, quite honestly, with like their little tape measure or whatever they were using. I don't understand why that was even something that they needed to track. Yeah.
Okay, good, because forearm volume didn't change. The thing that they were actually training, no change. So what I'm looking at, or what I feel that I'm looking at, is statistical noise from an underpowered study, because we have non-responders. Now, there are non-responder strength training studies, but they're rare and these are beginners. So you would expect to see, just from a learning effect standpoint, after 4 weeks, an increase in strength. And you didn't really see that in either of the groups.
That's the problem.
You did, yeah.
That's the problem with them saying, but they were trending towards significance. Well, maybe not. Like, to your point, if it's underpowered, you run it again with double the sample size, and maybe it goes the complete other direction. Yeah, so pretty tough to kind of reach some of the conclusions they did.
So Tony asks, could be wrong, but hasn't BFR been purported to have a systemic effect? So it's more of a hypothesis than it is substantiated in any type of data. It's usually local. But I'm going to be on my diatribe for like maybe one more minute and then go. But the data is the data. It's no fault of the authors for the data to play out the way it plays out. Now, there was no power analysis. Could they have gotten more subjects? I don't know. Again, science is hard. I'm going to push back on the authors in a little bit, though, when it comes to the interpretation and the discussion points and in the conclusion. So this is where I feel there's a misinterpretation of the BFR literature as a whole. And there's a couple points to come off here. So in the discussion, they say the results demonstrated a significant increase of volume in the right arm, just of volume in the right arm. Didn't distinguish where the volume was coming from because the volume increased in an area that wasn't even trained, but they didn't say that in the discussion. They just said volume and grip strength bilaterally in the BFR group. And then to follow up, there was a tendency of greater arm circumference change in the BFR group. And then go on to kind of, basically we're championing tendencies and we're championing data that was non-significant in many places and not significant in even the area that was trained. And the metabolic hypothesis that they provide in regards to why hypertrophy happens, that doesn't apply here because the area that was trained didn't grow. A couple more, and then I'll stop, I promise. So they say the findings of this present study are in accordance with the literature in which a similar strength gain between BFR and traditional training has been observed in several populations, even at different intensities. That's an incomplete statement. That's an incomplete representation of the body of evidence, and I'll explain here in a second. They say, moreover, a recent meta-analysis concluded that the benefits of muscular volume and strength are greater when the low intensity training is performed in combination with BFR, given that the traditional training requires higher intensity. That's not a complete statement. One more time and I'll explain. These results suggest that resistance training of low to moderate intensity without occlusion do not alter the magnitude of muscle strength in the same way as BFR. That's just plain out wrong. So there's a preponderance of evidence in the BFR literature comparing low load blood flow restriction training to low load training. And in many cases, the low load blood flow restriction training wins, especially in muscle hypertrophy, also in strength. In those studies, typically they are volume matched, but they're not effort matched. So both groups do the 30, 15, 15, 15, 15 protocol with the same intensities, and one group gets BFR. So when you're working out at 20% of your 1 rep max and you don't have BFR, that's really easy. You're not fatiguing the muscles. You're not putting any type of mechanical tension, but the BFR group has the added benefit of BFR, which increases motor pool activation, exhausts the motor pool. So you get more activation. That's the mechanism or proposed mechanism. In those cases, volume matched BFR low load versus low load with no BFR, BFR wins. It's like a coupon. You can do less, but you get the same thing. However, that's what they're saying here with these conclusions in the discussion of this paper, but they're ignoring the other side of the evidence, of the body of evidence, when you equate effort. So when you take both groups to muscular failure, meaning the low load group has to do more work, granted, to take 30% to muscular failure, you have to do more reps, and that probably sucks. So you might as well put some BFR on so you don't have to do as much work. The point is you can grow with lighter intensities if you match effort. So you can't make these claims as fact when you're kind of ignoring that side of it. Now, if the argument is, yeah, but you can cut the volume in half if you just throw some BFR on, yeah, that's okay. But that's different than saying low load without BFR loses 100% of the time, because it doesn't.
at that point, it's just a logistical issue. How much time do you want to spend lifting
Sure.
20, versus, yeah, it's a pretty big reach there for sure. And I think it's kind of disingenuous because, like you said, it's not representative of what we actually know, because that discussion has been had many times now, and there's been systematic reviews showing that that's not the case. When it's matched for effort and intensity, no, it just is a matter of how much time and suffering do you want to devote.
Well, you were at my talk at CSM because you
Yeah,
introduced us at the, I mean, that was one of my big arguments, was that you actually don't need it. You just have to either get creative or you have to do some hard work. But the last thing that I'll say, and this is maybe just an oversight on their part, but in the conclusion, the very last paragraph, they state BFR performed with low to moderate intensity loads was more effective in increasing hand grip strength and muscle forearm volume in healthy young women as compared to the traditional training. That's not what they found. That's just wrong. They found arm volume, which was this. The forearm volume didn't change. So if you were to just read that in the conclusion, it would make sense because their exercise was grip strength, but they didn't find an increase in forearm volume. So I don't know why they said that in the conclusion. That's not semantics. That's just incorrect. So I'm done. I'm off. Sorry, everyone. Kevin, do something.
what do you want me to say? I mean, I called the paper trash, man. So I think,
That was mean.
if
Can't polish a turd, Tony says. So
like, this is some of like the blowback on like IJSPT too. Is like they've kind of had a history of publishing some of these studies where and it's, what is this, like level 2A, right? Evidence or something like that, because it was a randomized trial. 2B, yeah, that's tough, man. It was not a good decision, I think, to kind of let this one come through.
and this journal publishes good papers, but they also, yeah, you'll get these that kind of make your head scratch a little bit. What's everybody else think? I mean, if there's nothing else on this paper, we can, get questions about the Patterson article. Beth says, may have missed this, but have you guys found that there is an ideal ratio for BFR load compared to non-BFR load if you want to keep the volume and effort the same? That's a good question. So the question is now, okay, so now let's compare high load to BFR, because we've already established BFR low load versus low load BFR, or versus low load no BFR. Volume matched, BFR wins. BFR with low load versus no BFR low load. Effort match, taking every set to failure, usually equal muscle hypertrophy. But when we start to increase the intensities, we start to see that we know from just training evidence over the last 40 years that high mechanical loads can increase muscle hypertrophy. They can also increase strength. What's interesting is if you add BFR to high loads, and then you compare that to high load with no BFR, there's not really a benefit to the BFR. So high load just almost just supersedes whatever benefit you're getting from the BFR. So now the question is, where's that inflection point? Where do I go down in intensity to the point where now it's no longer high load and BFR will be of added benefit? And I think that's what Bess is getting at here. And I don't actually have the answer. I think it's probably somewhere in the 60s to 70% range, because that's where you see the delineation happening in the literature, and you start to see less and less effect of BFR as you approach that 60% range. So I think maybe hopefully that's the somewhat of an answer to the question. Somewhere in the 60 to 70% range is a rough cutoff of that inflection point. Taylor, yeah, I can give you a whole host of them because I have an entire combined sections meeting presentation on those things. So Taylor wants to know if there's any references to load BFR versus low load taken to failure. Just shoot me an email, Quinn@clinicalathlete.com, and I'll send you those. Anybody? Jessica, I'm going to record this It was a year ago. So this is CSM last year, but I'm going to just record it and probably put it up I'll put it up. I've been saying I was going to record it since February of 2020, and here we are. But yeah, I'll do that. Go ahead, Antonio.
Hey, what's going on, guys? Can you hear me?
Yes.
Great. So yeah, just want to kind of just put my 2 cents into this. Kevin, you really knocked it out of the park, man. I know every now and then I come online and I, play devil's advocate, but welcome to the dark side, man. Thanks for telling, saying what I was thinking, man. I really had a lot of feelings about this article. And the one thing that really killed me, and this really, I just wanted to say is that, it's very rare to find studies that are performed on females. And once I saw that title, I'm like, ooh, this is going to be nice. This is going to be a really good home run. I just saw the title. I'm like, great. We got some information and studies for females. That's perfect. And then I just went and just kept going. And then just the despair just kept building up more and more inside, man. It just killed me that, we had a good chance. We had, a good sound hypothesis, but I tried my best to figure out where they went wrong. And Quinn and you said it best, man. A lot of too many outliers in here. So that's what I just wanted to say.
Yeah. A couple things. And could we have doubled the sample size and saw something different? Yes, absolutely. But again, research is hard. So that's just one of the pieces. For me, my issue was with the interpretation of the data. And so this is a good example of why we don't want to be abstract hunters. Because if we only read the abstract here, we kind of get a different picture of what the story that the data tells. I'm just reading Quentin's.
Yeah, there's a good comment here.
What's he saying?
Oh, it's a long one. Quentin, do you want to just unmute yourself and kind of get across what you were saying?
Yeah. Can you hear me?
Yep.
Yeah.
Awesome. Yeah, no, I was just thinking the premise of the paper, even in the introduction, they mentioned in painful populations or those with OA. And, I was just kind of thinking, I know you got to start somewhere in the research, so not a fault on that part of the science, just that I think that drastically changes the conversation of why use BFR if we're talking about those with pain. I guess reading the Patterson paper, a lot of the interventions were used for that 1 to 3 week interval. And then what they kept showing was that strength gains, over the long term, and even mass gains over the long term using non-BFR stuff tended to be about the same. So, I guess it just didn't make sense that if we're going to use this in those with pain, for instance, to get them maybe some short-term muscle mass gains in the 1 to 3 week interim, I don't really see that being incredibly important when it comes to long-term function and the actual strength output from these people. So I guess it just kind of seemed like, well, maybe just gaining some extra meat for the sake of gaining some extra meat, but it didn't really seem like, in the long term that it really mattered. And then if we take into consideration pain and all the other biopsychosocial considerations, I think that conversation can grow far beyond what maybe just mechanically we look at with BFR.
I think that opens up maybe a good discussion before we go to breakouts, and probably as we finish up afterwards is just kind of like applying BFR clinically. So I'm not anti-BFR. I've used it on myself. I've used it with patients. It's not very often, and typically only lower extremity. But sometimes it's just about finding an entry point to load. So don't think of BFR as this some type of separate modality that's separate from exercise. No, it's just a way to load. And it's a way for somebody to get some type of training effect with lighter loads if higher loads are not tolerated or contraindicated, maybe after a surgery or something like that. It's a way to get to an adaptation threshold in a shorter amount of time or with maybe potentially less volume. So it is useful from that perspective. And I agree with you in a lot of the ACL literature, the long-term outcomes tend to kind of pan out and be the same, but one argument could be made that if you could gain more muscle in the beginning of your rehab, then is that a bad, I mean, what's the downside of that? So it can be useful from that perspective. Somebody who, only feels their thing, whatever they're coming into you for, they're just fixated on that feeling. Another application of BFR is because it burns so ungodly much. If anybody's not done BFR, I suggest you do it just to feel it, but it's intense. And sometimes it's just like, holy crap, I can work hard. So we talk about like psychosocial effects. It can push somebody to a state of exercise in which they haven't felt in a while. And sometimes that can be powerful as well. So there's application for this modality. My diatribe earlier was more about that particular paper and not on the modality of blood flow restriction as a whole. So I kind of want to clear my stance on that.
I agree. I mean, I use BFR pretty much almost every day, I would say, but it's more so because it's given the constraints of the situation, right? So just trying to provide some sort of sufficient stimulus to drive the adaptations, especially if we're talking like somebody, post-op that maybe is limited weight bearing, meniscus repair or something like that. It's a tool like anything else that I think is useful kind of in those periods where you're not able to maybe drive some of the external loading that would be needed to get some of the adaptations that you're after. So I'm definitely like pro BFR. I think it's been a great thing from a rehab standpoint, especially for kind of like the early post-op stuff. Some of the literature around like bone is pretty interesting too, which is not fully kind of panned out yet. But so I think I'm definitely pro BFR. It's not a knock on the modality at all. I just think that like anything, it's there's a time and a place for it. But if we're trying to make arguments that it is superior when we're not accounting for things like intensity and matching total volume, I think it's just kind of misguided. So that's kind of my stance on it. But I think Quentin brings up a good point too when he's talking about utilizing research. Like I think the best thing to think about is, one, how does this apply to populations that I'm dealing with on a day-to-day basis? So if we're reading a paper and it's dealing with a population like young females, right? Suppose that like the conclusions would have been different in this. I think that's something to consider too, just as you're reading research, is does this apply to the clinical population that I'm actually treating or engaging with? Because I think sometimes we can do a little bit maybe go too far and kind of using some of the research to intervene on populations that maybe were not studied in that. So there's a certain amount of that I think you need to keep in mind when you are reading studies. If it was done on a pain-free, young, healthy female population, and you're dealing with, chronic pain, elders, I think it's something to always just kind of reflect on is, does this really apply to my clinical application, or my clinical population? So the external validity is something to keep in mind, I think, always when we're reading research.
And that may be a good cue to go to the Patterson article for people, if you're looking for an overview of what populations we're looking at, because a paper like that, you can start pulling the individual papers that it's referencing. But Quentin, did you have any response to anything we said? I want to give you a chance to respond if you have.
Oh, no. I think
Okay.
you guys made some really great points. And not to necessarily downplay BFR as a whole, just kind of the premise of some of the things they were arguing for in the introduction, it didn't really pan out well in this particular paper. And then in the Patterson paper, there's a section kind of towards the beginning where they just talk about how hypertrophy and strength has been shown to be pretty comparable in non-BFR training groups at 5 weeks, 6 weeks, and then 8 weeks or greater. And so I guess my point was just like, just to add a little question or skepticism to the pot to stir around a little bit to stimulate some conversation. But no, I mean, great points and definitely has a place in therapy for sure.
Well, I think you bring up a good point in that, are you missing something if you don't use BFR? If you've just, for whatever reason, you're just not going to use BFR, and you see post-ops, you see all different types of levels of athletes, and you just don't use it, and you will never have used it, are you somehow missing something big? And I don't think that would be the case. You're potentially missing in those cases where it's really like, oh, BFR would just be really nice in the scenario. There's no contraindications. They want to work hard. That's where it's like, oh, BFR kind of it's like kind of get excited because it's like, oh, I do have, you know, kind of an entry point to load here, but like, what if you didn't have that? Would you ultimately for this person they wouldn't have the long-term outcomes that you wanted? Unlikely. And I think, you know, we get, blood flow restriction is funny because it's one of the few things that we have in our field that actually has some freaking data behind it, and that we can actually like measure adaptation from this thing, that if we do this thing versus if we don't do this thing in certain conditions, it consistently gives us better results. We don't have a lot of stuff like that. And so we get excited about that. And then BFR gets put on this pedestal, or whatever it would be in that scenario, gets put on this pedestal as something different or special, and, you know, can be taken far ahead of its application, or you know, proposed to do things to take the place of heavy lifting, you know, progressive overload. And it's not, but it's certainly something there. It's a tool in the toolbox if you know what tool you're looking for and for the job that you need it for. I say, let's go to the breakout rooms. So we're going to kind of talk more generally in the breakout rooms about BFR. So there's a prompt in the chat. What is your experience using BFR? Any situations? You guys can kind of talk through that. Going to the Patterson article, have you used blood flow restriction training for aerobic exercise or even without exercise? So, you know, in those scenarios where they're just putting the cuff on and basically inflating it to full occlusion pressure and just chilling for like 5 minutes, and then deflating and doing that for, you know, 2, 3, 4 sets, has been shown to, in some studies, to mitigate atrophy when you can't move or can't load. It's all contraindicated, but you can load in that way. And then the third prompt, if you're running out of things to talk about, which I don't think you never are, were you surprised by any of the findings of the Fernandez study? Okay, we're going to go to breakout rooms. Highly suggest that you stick around, but if you don't want to stick around, go ahead and leave us now so that we can be even in the rooms. But you should probably stay. Okay. Here we go. All right. We are back. Mark, I got you. You got a question, but just real quick, before I forget, just because people were asking me, I'm just going to put I thought I was going to do it. I'm going to put my slides from that combined sections meeting presentation that I was talking about. I'm going to put the PDF for the slides here in the chat. Just because you guys are asking for references, and there's tons of, that's the whole talk. So there's that. Now, just know that one reason I don't share slides is because PowerPoints make for really crappy handouts. So some of the slides have, you know, animations and pictures on pictures. And so those won't be readable, but a lot of the slides will be readable, and I'll also just re-record it and post it for people. But I think that'll be helpful. So that's open that up in the chat so you don't lose it when we close out of this thing. But Mark, go ahead and ask your question.
Yeah, just real quick, I was thinking this while we were talking. Has there been a comparison in the literature to, like, in terms of like ACL rehab or like total knee rehab, like comparing NMES in early stages to BFR?
NMES without BFR versus BFR without NMES?
Yeah.
Kevin, do you know of any?
I feel like there was a systematic review where that might have been referenced most recently, because they were looking at, is there neural changes with BFR? But I can't remember off the top of my head, so I'm not sure on that. It would be kind of interesting, though. I guess the idea would be kind of different mechanisms for kind of same changes that you're monitoring or whatever. But I couldn't tell you for sure. I don't know.
Mark, you might check that Patterson article, because they have that paragraph on NMES. I don't know if there was a paper like that, they probably would have cited it there.
Okay, sweet. I will check that out.
That's
Thank you.
interesting. Yeah, for sure. Interesting question. Kevin, what'd your group talk about?
We talked a lot about just kind of general uses in terms of like exercise prescription, different populations that it may be indicated for versus not. And then Quentin had some pretty interesting discussion on looking at just using near infrared spectroscopy and muscle oxygenation, and kind of just trying to figure out what exactly are some of the mechanisms behind BFR, which was pretty interesting. But overall, it was more just kind of, we have this tool. Do we really know some of the mechanisms behind it? Where is it indicated? Where is it not? It was a good discussion overall.
Yeah, if anybody's got thoughts on those, unmute yourself, throw them in the chat. Megan, did your group have similar talking points?
A lot of similar. Towards the end, we kind of started talking about, I think most people's experiences have been using BFR on a patient population that is maybe a little younger, a little more athletic. And so we're just kind of starting to talk about how you might get like an older individual to buy into something like this if they know it's going to be not comfortable. Or how kind of it's used in a population that's more obese type thing. That's kind of where the conversation left off. I don't remember who brought that up.
I think it's a good talking point. There's a lot of the data is on OA. Pretty successful management of OA with BFR. I don't know if age has much to do with it in terms of being okay with working hard. I think that's maybe more of a history of training and kind of a per individual thing. Like if somebody has trained and been active their whole life and they were used to exercising hard, and now they're 65 and instead of 20, they're probably still kind of all for working hard. And like I said earlier, the sensation, if somebody's just been feeling their thing, like they've just been feeling that deep bone ache forever, and now BFR gets them to feel that muscle burn, they're like, hell yeah, I haven't felt my quad in forever. And so there's a lot of anecdotes like that. At least I've had those personally. The obesity thing's interesting because you start to run into issues with the equipment. And being able to accurately measure limb occlusion pressure and these types of things. If anybody's got experience there, that could be helpful. Studies on individuals with sarcopenia or osteoporosis using BFR. Yes. There's quite a few papers on postmenopausal women and with success, with BFR training with success. Really, anybody that you're looking to gain muscle mass and somebody who can't do heavy, high mechanical loads, and they also don't want to do 1,000,000 repetitions. And you're just looking for something to kind of jumpstart. It's almost, like I said, it's a coupon. You end up buying the same product, but you get it for a little bit less. And you don't get as sore because the loads aren't as heavy and you're not doing as much volume. So, I mean, those populations, obviously, save for any glaring contraindications, which you can kind of check out in that Patterson paper. Is it Patterson? Yeah, those would be really good populations for it. As far as buy-in, again, it looks kind of, I guess, scary though. If you're a patient and it's just a thing, like, what are you doing? You're pulling out this cuff. And if you frame it in that, no, it's just a way to create an exercise stimulus. It's not this magic thing. It's not this scary thing. It's going to burn. But at some point in a person's life, they've probably experienced muscle burning. So you just kind of take them back to that experience. You remember how it like really burned and you were like, well, that's just kind of how it feels, this time around. But I've not had an experience where after it was done, the person was like, man, I just really regret doing that. They might say it in the middle. that starting that third set of 15 when it really hits you is pretty rough. But
I think the worst is the rest period.
yeah, when you don't, because they generally recommend don't deflate the cuff, just keep the occlusion out, man.
Just sit there and it's just like, the worst is the rest for sure. And
then when you release it, you're like, oh my God, it's the best. You just do it. That's why you do the BFR, just so you can release it at the end. We're all about dopamine fixes here at the CALU Journal Clubs. All right. Katie asks, what do you use as indications that somebody is ready to migrate from BFR training back to more traditional exercise therapy? I think that's a really good question, because I don't think we have a great barometer. We know we want to get them there and just training normally, progressive overload and just your normal progressions over time as soon as they can handle it. So you might just be thinking like, the loads that you're working with the BFR, and if they're struggling with those loads, you just kind of it's intuition and based on what they've experienced with their training history in the past, and then some tinkering and introduction throughout the course. So I'm just throwing ideas out here, but maybe you're using like 30% of 1 rep max with BFR, but maybe a set or two before that, or 3 sets, you did 40%, or you bumped it up with no BFR, but you just kind of like introduced a new level of intensity on that session. Cause you knew like, oh, last session, they tolerated 30% with BFR just fine. What if I add just a little bit more? Is that really going to be a big deal? Probably not. And so you just kind of keep bumping that needle up. And then over time, as you're seeing that they're tolerating everything fine, recovery is good, you can just kind of keep that going. And once you're consistently using 60 to 70% of what they perceive to be their maximum, you're probably weaning them off of BFR, or just, you keep it in every now and then because they like it, that type of thing. Kevin, do you have thoughts on that?
I mean, you pretty much summarized my thoughts. I generally try to get people kind of away from it as soon as possible, more so, just because I think, like we said, systemically, we probably do get more of like a systemic effect from heavy strength training as opposed to some of like the BFR stuff. So outside of kind of like an early post-op population, non-weight bearing situations, once I have somebody that they're able to, kind of squat, hinge, lunge, do kind of more basic sort of patterns, I'm kind of moving away from that. I might keep it in if we're like load limited. Let's say you don't have access to a leg extension or something like that, but you do have, the ability to utilize BFR. Maybe for something more kind of proximal where you're just doing, long arc quad or whatever, and you don't have an ability to kind of load that up, maybe keep it in there. But generally, I'm trying to kind of move away from it once they have, some level of competency and we're kind of back into more just kind of general strength training.
I think just keeping in mind that BFR is not the goal. The goal is the adaptation, and the goal is just pushing them towards normal, progressive, regular training as soon as possible, and just kind of checking in on the day-to-day to see if they can boost it, to another level or not. Swole is the goal. Unless you're a weight
And you had
class
also
athlete.
talked about like NEOA. You had also talked about like osteoarthritis, and a lot of my osteoarthritic patients, they have such big fear avoidance for squatting, deadlifting, whatever it might be. So that's possibly like reintroduction into, some of these loading aspects that SPTs like to do, that maybe these people who have had pain and suffering in certain parts of their body for a really long time, they just are super averse to it. So maybe once they can start doing, they do BFR mixed with like light loading once they can start trusting themselves and they go back to it. But I think like fear avoidance and pain also kind of plays into this, right? Like return to functional loading.
Oh, you're so right. Totally. And again, it's like we talked about, the BFR might just be another entry point, because it's that weird spot with the population with osteoarthritis, is where they can't tolerate the heavy loads or the high volumes or the fast velocities, but like doing body weight leg extensions is also not enough to do anything. And it's probably still sensitive to just rant with your leg, but throw some BFR on there and all of a sudden it's like, whoa, quad's burning. And is that directly specific to a squat from a force vector standpoint? Well, no, but it's exercise, and it's getting them to feel a certain degree of intensity that they maybe haven't gotten to. And then to your point, maybe it does say, okay, let me see if I can kind of push into these squats a little bit with or without BFR. Maybe it's like you said, it's a nice little mix of getting them to do the complex movements, squats, hinge, some type of modified lunge, whatever it is. And then you can supplement with the BFR where they don't have to think, they can just do the work. And it's low cost, high return, at least for that short term. And I don't want to totally poo-poo on short-term things, because we literally live short-term in every moment. The person's in front of us. We're looking for that thing to do now that's going to get us and nudge us in the right direction. And this is certainly an option. But I think you bring up a great point. For healthy people, there's maybe no application other than if you just want like some novelty in your training, you throw BFR in for a few weeks just to go ham. Some of your accessory movements are getting like kind of old and you're bored. You throw some BFR and go to town. Anything else from anybody? BFR,
That's something we discussed in our group actually, was if you have somebody that is maybe a little bit more fear avoidant with some of like the traditional more external loading that we know is going to kind of promote the adaptations or the changes that we want. I think this is something that Quentin and I talked about was, if you have somebody that is, either doesn't have an extensive training background or are, hesitant or have some element of fear avoidance with some of the heavier loading that we feel like they think they need. Well, now maybe, we throw a couple cuffs on them and they're doing body weight squats or something like that, or a goblet squat. It's still, some sort of movement it's kind of like meeting the person halfway, right? So you don't feel comfortable kind of pushing some of the heavy external loads, but I know that you kind of need some of the changes that this is going to provide. All right, let's use this in kind of the interim period to kind of get what we both want a bit without having to necessarily force somebody under a barbell or, or something like that when they're just not having it.
For sure. Anybody else? All right, we're all BFR'd out, or half the group has like an ace bandage wrapped around their arm right now, just kind of doing some curls. Cool. Okay, this was a good conversation, everyone. Check out the 2 ace bandages. Nice. Make sure you wrap it real tight. If your fingers are turning blue, that's where you want to be from an occlusion pressure standpoint. Just kidding. Don't do that. Let's edit this out. Megan, edit that sentence out, please. Post-meeting surveys in the chat. Open that up for feedback as how we can make these things better for you. And open up any links that are in the chat if you want those saved. And we'll vote for upcoming topics in the Facebook group. What am I missing? All right. This one was fun. Thanks, Kevin. Thanks, Megan. Thanks, everyone. See you next time.